Let's go to what we have for you today. Now, good morning, everyone, and welcome to FCT Brief. President Bola Tinubu has approved a subsidy on the cost of kidney dialysis treatment across the country. The move is expected to ease the financial burden on thousands of patients and their families. For many Nigerians living with kidney failure, the cost of dialysis has been an overwhelming challenge, with treatment sessions often priced beyond the reach of average citizens. But in a new policy intervention, President Bola Tinubu has directed that dialysis services in federal hospitals nationwide be subsidized. The government says this measure is part of its broader healthcare reform agenda under the Renewed Hope initiative. Health experts estimate that over 20 million Nigerians are at risk of kidney disease, with thousands requiring regular dialysis to survive. Now, a single session currently costs between 30,000 naira and 50,000 naira, and most patients need at least 2 or 3 sessions every week.
Under the new subsidy arrangement, government officials say patients will now pay significantly less, making life-saving treatment more accessible. The government also plans to expand dialysis centers, ensure the availability of consumables, and train more medical personnel in nephrology care. While patients and advocacy groups have welcomed this subsidy, they also are urging the government to sustain the policy and extend it to cover kidney transplants and post-operative care. As a nation grapples with rising health costs, this intervention is seen as a glimmer of hope for many Nigerians fighting chronic kidney disease. Dr. Babatunde Ipaye is a public health specialist and the former Commissioner for Health, Ogun State, and he joins us live here in the studio. Thank you so much for joining us on the program this morning.
Good morning.
Thank you for coming.
It's a pleasure to have you here. Well, let's begin. Subsidy on dialysis is commendable, but the question now is how many public hospitals even have functioning dialysis machines, and are they nearly enough?
Well, good morning. So let me start by saying this is a welcome development. If you look at the Nigeria sector space, the mechanism for financing has always been input financing. Input financing is where you give budget to administrators to administer, and then the administrator use their prerogative to allocate how to use the resources, sometimes not for critical care. Okay, I give $1 billion to a teaching hospital and the CMD decides to fence the hospital. Okay. Also, fencing will not give critical care to people in need. So for some of us who have advocated innovative financing mechanism for a system, where government begins to buy services rather than provide inputs, okay, we'll do 3 immediate things. The first thing it does is that it makes services immediately available to people. Because now you are not giving money to the CMD to do whatever they like. You're actually subsidizing or buying services, right? The second is that it brings access. Okay, people now have access to that care because you are no longer paying for what they need to put in place. Somebody needs to put that services in place before you can buy from them. So the hospital will be compelled to focus on service provision. And the third, the most important thing is it brings what we call public trust. Okay, so for me, this is very innovative. And I'm not surprised because of the leadership of the country at this time. So when you subsidize, what you are doing is to make this more available to people who ordinarily cannot afford the 50,000 that a dialysis would naturally cost. And averagely, a patient who requires renal dialysis may need at least 1 or 2 sessions per week. And they need this for the rest of their life until a transplant is done. So imagine paying 100,000 per week for the next maybe 5-10 years of your life. So how many Nigerians can actually afford that? So for me, this should be celebrated and it should be expanded. I am told that this is going to start in about 10 facilities from Maiduguri to Jabi to Abeokuta to Owerri to Uyo to Calabar across Nigeria. 10 centers have been approved to over these services. Of course, I'm aware that there are several more centers that could provide dialysis services in Nigeria, but to answer your question directly, we do not have enough. But the incentive here is that if government is able to pay for services, many more people will come to provide the services because they now know that government is willing to do what we call performance-based financing.
Okay. Now, let's look at it this way. Rather than have a system where like these kidney dialysis centers now want to spread it, every state will have it. Why don't we also have a system where we look at Nigeria through the geopolitical zones and say, okay, in this particular geopolitical zone, we have one major dialysis center that is of international standard. Then you look at another one, you say, okay, cancer, for instance. So that at the end of the day, we're not just dealing with one ailment. We're spreading it across the country that, okay, we have one center that is expert, that have the major international equipment, another place and all that. It's not possible to have it that way.
No, so you need to understand the epidemiology of the disease, what we call disease distribution in population. Okay, so if you put, for instance, a regional center for dialysis, the indirect cost of accessing that cheap service becomes more expensive than the cost of service. For instance, if I have to travel from Ogbomoso to Lagos to do dialysis, the cost of transport to Ogbomoso and back to Ogbomoso to take dialysis of 12,000 is more expensive than the cost of dialysis. Okay, so and the prevalence of renal disease is on the increase, and renal patients are everywhere in Nigeria. They're in every corner in Nigeria, and dialysis today is not a complicated science. I mean, they are portable, and a more concise unit that could actually be established. I mean, for me, in every local government of Nigeria. Okay, because one fundamental thing about access is that must be taken to people, to the community where people live. And part of the indirect cost of health is that people will still have to live their daily routine, their daily work. You know, many Nigerians and they are living daily. Okay, many people have to, wake up in the morning, get to provide service somewhere and be paid for that day. And the moment you allow somebody to travel a whole day and come back a whole day, it's another indirect cost. So dialysis, for instance, I mean, cancer, for example, you could have regional or state level services because it's not as prevalent. Okay, or cancer services requirement is not as common as renal condition, right? So for me, the requirement for renal services in Nigeria, I mean, needs to be expanded. The provision and the center to provide service needs to be made more available to people, even taken as low as state hospital, general hospitals, so that as many as possible Nigerians, people are dying every day because of inability to access, dialysis. And the dialysis is just one science that will keep patients alive. And like I said, and like federal government had committed, many more centers who are already providing services will also be supported by this subsidy scheme. And I also hope that maybe state governments, will also take this forward.
All right, Nigeria has only about 250 nephrologists for millions with kidney disease. Doesn't this intervention risk failing with this limited amount of nephrologists that we have in Nigeria? Yes, I mean, we do not have enough of any cadre of service providers. Even, nephrology is a specialized care, right? Even for things like, general practice, general duty doctors, we don't have enough, talk less of the specialists. I mean, if you even go to the, primary cares, where we even need community extension workers, Nigeria never had enough. And in the middle of not having enough, we also lose a whole lot to the pool effect, what we call the brain drain, right? But having said that, there are ways to make sure that even when you don't have enough, you can innovatively expand services, okay, where you have other levels of care of professionals, trained in how to support the 250 nephrologists that you have. So the 250 nephrologists will be the first point of care that do the diagnosis and recommendation. But continuous care, you don't need nephrologists to carry on continuous care. Okay, you can actually, like it is done elsewhere, even if you go to the NHS in UK, you have nurses or paramedics that have been trained on how to help administer, some level of care, including regular dialysis, even at home, okay? And then people can take care. And so when there are complications, then they be referred back to the nephrologist. All right, we still have more to discuss about this government intervention, but we'll take a quick break now. Don't go anywhere. We still have more for you on the program. Stay with us. We'll be right back.
More nutritious meals, more veggies, but we want it tasty and easy too. Knorr Cubes, that's the secret. Made with real ingredients like chicken, parsley, and garlic, and enriched with iron, so your meals are better for you and more delicious too. That's the cocoa. Let's give it some accolades. Change your world by changing what's on your plate.
In the beating heart of Owerri, business never sleeps. From sunrise to sundown, the wheels keep turning. And behind the scenes, vision meets action. Governor Hope Uzodimma's leadership has turned manifestos into reality, transformations that feels like a miracle. But progress needs peace, and in Imo, it's not left to chance. From land to sky to river deep, guardians are watching, protecting dreams and opportunity. At Orashi's quiet shore, hydropower is rising, set to energize a growing economy. The change is visible. New roads emerge, industry hums, communities come alive. At the center, a digital revolution. 500,000 young minds trained each year to build the future. As Orashi rises, so does Imo and the hopes of a hard-working people. A new Imo is on the rise.
Chef. Mr. Chef, what's your secret?
My secret is the wide range of seasoning powders from Mr. Chef. Perfect for meals such as spicy stew, goat meat, roasted beef, fried rice, and kuka.
Unleash your inner chef and explore our wide range of Mr. Chef seasoning powder.
Thank you for staying with us. You're still watching TVC Breakfast, and this is FCT Brief. We're still discussing subsidy on dialysis, and with us in the studio is Babatunde Ipaye, a public health specialist.
Doctor, months after this subsidy was approved by the president, there are still some hospitals that have not started implementing the reduced cost. Now, are there plans in place to monitor and ensure compliance with this presidential directive? Then the other one is it possible also to bring in the private sector to fund this? Now, this is the government now, bring in the private sector, because people are also talking about kidney transplant, so that the scope of care will be expanded to involve the private sector and all that.
So my expectation, of course, I don't work within government. I'm more of a private sector person now. Of course, I served government in the past. My expectation is that when you have a policy direction, you must develop an implementation arrangement and a mechanism for monitoring and implementation. If you look at the leadership of the sector today, Professor Pate has been in the development sector, and Dr. Salako are people who have the capabilities, to actually design a system that is enduring and sustainable. And I expect that maybe the last few months was actually used in designing and ensuring that once this starts, there'll be a monetary framework that looks at performance and productivity. Remember, the first thing I said that this is innovative in itself. It is one thing to throw money at a problem. Because Nigeria will love throwing money at a problem, but the money don't get to solve the problems. Exactly. Okay, so my expectation is that the Federal Ministry of Health and their partner centers will have an implementation arrangement where those who have truly undertaken dialysis will be confirmed. For instance, I lead an organization that does independent verification of investment by the World Bank in Nigeria, Malaria project. Okay, and it is our report of validation of outputs that define how the NSAs are paid. So my expectation is that there'll be a mechanism where there'll be an independent verification of services provided before further subsidies are given. Okay, so that answers your first question. The second thing you're asking is the involvement of private sector. Of course, see, if you look at the national health account in Nigeria, an average Nigerian spends roughly about 70%. I pay for about 70% of SRVs out of pocket. Okay, and per capita investment in health is just about $100 in Nigeria. Of course, it's very low when you compare to other countries. If you compare to South Africa, that's about $500 per capita, right? But even at that, 70% of that income comes from the pocket of Nigerians. And Nigerians where disposable income had reduced from about $460 in 2015 to about $200 in 2024. You know, right? And so when you get to a point where people need to pay out of pocket, you must also, because 12,000 out of pocket, out of the 50,000 that is subsidized, is still significant payment. Yeah. Okay? And people must be given the choices of where they access services, because this is also part of public trust. And medical, information and data analysis in Nigeria has shown that in some part of Nigeria, private sector provide as high as 60% of healthcare services that is being provided within those areas. And so how do you expect 60% of population to access service if you don't involve the private sector? So my expectation is that this is the first phase of engagement. Of course, I am told that many more tertiary institutions will be enrolled. And I hope that in the next phase, of course, private facilities, because there are several private rental assets, and these assets must also be energized through this subsidy scheme.
All right, you spoke about the country being reactive rather than responsive in responding to challenges or problems. Kidney disease is rising due to fake drugs, contaminated food, and synthetic products.
And lifestyle.
And lifestyle as well. Shouldn't we also consider strategies to addressing these root causes rather than just always looking for solutions to them?
So there's what we call epidemiological transition. And when you are transitioning epidemiologically, which is due to, of course, development, I mean, the more civilized a country becomes, the more we transit from the infectious diseases to what we call the transition diseases, or what we call the chronic ailment, hypertension, diabetes. And once there are high incidence of hypertension, diabetes, due to our lifestyle changes, of course, renal cases will also be a natural consequence of high blood pressure and diabetes. Okay, so it is unavoidable to some extent, because we eat more sugary things, we eat more salty food, we have deviated from the natural food system, we eat more thin food, because you wake up very early in the morning, you have to come to TVC, you have to take something very snappy. The snacks that we do, these are cholesterol, sugar, salt, and of course they lead to metabolic condition. Metabolic condition leads to renal complication. So yes, of course, like you have said, there's a role for the kind of health services that I provide. I'm a preventive health specialist, okay, to educate people, to make sure that people take less of a risky, behavior, reduce alcohol intake, less of sugar, do exercise, and eat more natural food. Okay, so these are things that must go on, at the same time. But you won't focus on that alone. I mean, the problem is with you. You've got to resolve it.
Now, let's look at this other aspect, the primary health care. My worry is a lot of time we talk about the federal government providing health care, and we talk less on the various state governments and local governments.
And it should actually be the other way around.
Exactly. So why is it difficult to have our state and local governments pay particular attention to growing the primary health care so that we'll reduce the burden on the tertiary?
So I think the right word to use shouldn't be a difficulty, because the primary care is the simplest care to provide.
Okay.
So it is, I mean, the word difficult should not even come in the lexicon of primary care provision, because by definition it's a simplest, affordable, easy to provide care, easiest to make available. Yeah. And it is actually the requirement of the majority of the population. About 80% of the population actually require primary care. Yeah. And most of the problem that we take to tertiary centers can be solved at the primary care level. I'll give you an instance. When I was commissioner for it in Ogun State, I discovered that 60% of patients in my secondary facilities are primary care patients. Malaria, cough, pain, headache. These are things we get at primary care level in other climb. That I'm even paying specialists to treat that is inefficiency, right? It is misapplication of fund, right? So I think what it requires is political will. So it's a political will and the need for Nigerians to refocus that government in Nigeria is not only at the federal level. And people must call government at subnational to question, particularly at the local government level, because health is on the concurrent list of the Constitution, for heaven's sake. Okay? And primary care centers are everywhere in Nigeria. So what do we need to do? We just need to make them functional. And all they need to make them functional, get community extension workers, community workers. These are, I won't call them low-level care providers, but these are people who are easy to recruit and pay. and keep them and give them a good condition of service, okay, train enough, and then make them available and make the consumables that they need to use available. And when they are available and present, so I use the word present deliberately. When they're available and present means that patients get there at 10 p.m., the primary care is opened. Because anybody can have headache pain or labor pain any time of the day. So if we have functional PHC, we'll have less need for tertiary care because most of the problem will have been managed and complication will be less. And we'll be paying less for tertiary care, which is very expensive. So my conclusion is that, I mean, we need to advocate more at that level, especially as Nigerians, and hold people who have resources at that level accountable and make them provide that level of care because that will solve most of the healthcare need of majority of Nigerians.
All right. I like the point you took the conversation, but we'll continue right after this short break. We need to take a short breather now. Don't go anywhere. There's still more for you on the program. Stay with us. We'll be right back. Glad to have you back. This is still FCT Brief, and we're still discussing government interventions in the health sector. We still have with us in the studio, Babatunde Ipaye. Now, you were speaking about holding those that have been put in charge of these services accountable for effective, delivery of their services. Health insurance enrollment is rising, but treatment options remain narrow. What reforms would you say would make insurance genuinely protective instead of being cosmetic?
Okay, thank you. So, this is a very interesting area. Every system or a system that is functional globally, a system backed by insurance mechanism. Okay, so the biggest issue around the Nigerian sector is that we do not still have what I call a functional, population based and acceptable insurance mechanism. A mechanism that has less than 10% of people under cover is not an insurance because insurance is about pooling risk, is a pooling resources and sharing risk, right? Every form of insurance. And so for your country insurance to be described as fully functional, you need to have at least minimum of 50% of the population on your scheme. In Nigeria, we are still at about 5% of the population. So we are not pooling resources. So to answer your question directly, the innovation that we need around reinvigorating Nigerian insurance system in terms of law and policy had been established. What is left is to have the desire, the will to implement. Nigeria is a country of good policies. Okay, that problem is execution. So because the initial scheme, which Obasanjo started in 1999, had a voluntary scheme where you either take insurance or you don't. And no country runs an insurance scheme like that. So in the last 2 years, I think about 2, 3, 4 years ago, okay, that law was now, rejigged. And the National Health Insurance Agency was established with a new law that makes health insurance mandatory in Nigeria. So if health insurance is mandatory, why do we have only 5% of Nigerians covered? Okay.
That's a big question.
So that's a big question. So if you have a law that says health insurance must be mandatory for every Nigerian above this category, employer of labor, private sector, so why is it not being executed? Why is the law that we have passed by our parliament not being implemented? And so I take it back to the political will at all levels. Every state government in Nigeria also had insurance law that had made insurance mandatory. Okay? And many of the states, even the civil service, is not even on the insurance scheme of the state. And so why do you have a law, passed by the assembly of a state, signed by the governor of the state, paying the salary of the civil service and the public service, and the private sectors operating in that place, who pays taxes, who government collect taxes from, are also not made to enroll their services. So our problem in Nigeria is execution. And so you can have a beautiful law, you can have a beautiful design, you can have a beautiful decision, policy reform, you can have executive orders. The most important thing is that there must be the deliberate intention, okay, to make, and until we become very firm as people, either as government or as people who should hold government to account. Okay, I mean, we won't, I'm sorry to say, we'll just be paying lip service to all of this. See, I was in Kenya about 2016, and I saw Okada riders in Kenya, gleefully go to pay their 15 shillings into national insurance scheme. You know why? Because you know that if you pay your $15,000 and you need renal transplant, you're going to have it without anybody asking for any other money. Public trust. And it starts by strategic execution. And execution will mean that you put the right persons and the people who have the right framework, who use resources judiciously, and the member of the public will trust in the scheme. And so it is a trust that makes people park their Okada to put their money on the insurance scheme because they know they're going to get services after making their contribution.
Right.
So we need a whole lot of public enlightenment. We need a lot of confidence building. We need a lot of resource pooling. We also need to reposition our primary care to make services more available in a more trusted way, so that people will willingly, support government in implementing good policies.
Babatunde Ipaye, it's a pleasure speaking with you this morning. We really enjoyed your insights on the show. We hope to have you back again some other time. This way we'll leave the conversation this morning.
The pleasure is
Thank you
mine.
so much.
Thank you. And thank you, Nigerians.
Thank you for being a part of our conversation this morning. We'll now hand you over to Lagos, where Ibrahim and the rest of the team are standing by to continue with the rest of the show.
Thank you so much, to Jesu Adeoye and Eshemomo for helping us understand this very crucial topic better.